Make sure to sanitize your hands at beginning of the examination. The Snellen chart consists of a series of letters with a corresponding visual acuity number at the side. The top number indicates the distance of the patient from the chart, and the second indicates the distance at which a normal eye can read the line of letters. Ask the patient to read as many letters as possible with the other eye closed.
E F P T O Z L P E D P E C F D E D F C E P.
Position yourself an arm's length away from the patient. Close one eye and have the patient cover the opposite eye while staring at your open eye. Place your hands about 2 feet apart from the patient's view, roughly lateral to the patient ear. While in this position, wiggle your fingers and slowly bring your moving fingers forward into the patient's center of view. Ask the patient to tell you as soon as he or she sees your finger. Test each clock hour or at least each quadrant. For kinetic red target test, use a 5 mm red topped pin. Move the pin inward from beyond each boundary of the quadrant along the line bisecting the horizontal and vertical axis. Ask the patient when the pin appears to be red. At first, inspect the eyelids. Inspect the width of the palpebral fissure. Note for edema, color and lesions. Inspect the condition and direction of eyelashes. To inspect the sclera and conjunctiva, ask the patient to look up as you depress the lower eyelid with your thumb. Look for nodules, swellings, look for color and vascular pattern around the white scleral background. Ask the patient to look side and downward for better viewing of sclera. Now, inspect the lacrimal gland. Inspect the area of lacrimal gland and lacrimal sac for swelling. And look for excessive tearing or dryness. To inspect cornea and lens, with oblique lighting, inspect each cornea and lens for opacities. Note any opacities in the lens that are visible through the pupil. Now, inspect iris by shining the light from the temporal side. Normally, iris lining should be clearly defined. By shining the light from the temporal side, look for crescentic shadow on the medial side of the iris which suggests glaucoma. Now, inspect the pupil. In the dim light, inspect the size, shape and symmetry of both pupils. Note if pupils are large or small. The light reaction. In dim light, test the pupillary reaction to light. Ask the patient to look into distance and shine a bright light obliquely into each pupil in turn. Both the distant gaze and the oblique lighting help to prevent a near reaction. Now, look for direct reaction consisting pupillary constriction in the same eye. Now, quickly swing the light to the other eye, looking for the consensual reaction, pupillary constriction in the opposite eye. If reaction to the light is impaired and questionable, test for near reaction. Hold your finger or pencil about 10 centimeters from the patient eye. Ask the patient to look at it alternatingly and into the distance directly behind it. Watch for pupillary constriction with near effort and convergence of the eye. To test the extraocular muscle, assess the ocular alignment arising from the extraocular muscle. Stand 2 feet directly in front of the patient, shine a light into the patient's eye, and ask the patient to look at it and inspect the light reaction in the cornea. They should be visible slightly nasal to the center of the pupils. Next, assess the extraocular muscle movements. Ask the patient to follow your finger or a pencil as you sweep through the 6 cardinal directions of gaze, making a wide hedge in the air. First, move the finger to the patient's extreme right and right upward and then downward on the right, without pausing to the extreme left, upward and downward. To detect the horizontal, vertical and rotatory nystagmus, look for the jerking. Look the movement of the eye as the patient look for the far left, then the far right and then up and down. If you suspect lid lag, repeat the procedure again. Normally, the upper eyelid should slightly overlap the iris throughout. Now, test for convergence. Ask the patient to follow your finger or pencil as you move it in towards the bridge of the nose. The converging eyes normally follow the object to within 5 cm to 8 cm of nose. To examine the auricle, begin the examination of the ear by inspecting the auricle and the surrounding tissues for deformities, lumps or skin lesions. If patient have pain, inflammation and discharge, if present, do the tuck test to test for otitis externa. Move the auricle up and down and press the tragus firmly. Press firmly on mastoid bone behind the ear. Tenderness here suggests mastoiditis. Now, examine the eardrum and ear canal using an otoscope. To do this, select the largest speculum that a patient ear canal can accommodate. Position the patient's head so that you can see through the otoscope comfortably. Straighten the ear canal by grasping the auricle gently and firmly. Pull it upward, back and slightly away from the head. Insert the speculum gently into the ear canal, directing it downward and forward, and then inspect the ear canal and the eardrum. To assess the hearing test 1 ear at a time, stand 2 feet behind the seated patient, occlude the non-testing ear of the patient with your finger and gently rub the tragus in circular motion to prevent transfer of sound to that ear. Exhale slowly and whisper combination of 3 letters or numbers near the patient ear and ask the patient to repeat it. Perform the whisper voice test as follows. Now I'll whisper few words. You have to repeat the same. Okay?
Okay, madam. JQK, A1B, E2C, K2M, MNO.
For patients failing whispered voice test, a tuning fork test helps to determine the hearing loss is conductive or sensory neural in origin. In a quiet room, select a 256 Hz or 512 Hz tuning fork as these frequencies fall in the range of conversational speech. Now, test for lateralization by performing the Weber test. Set the fork into light vibration by tapping it on your elbow. Place the base of the vibrating tuning fork firmly on top of the patient's head and ask the patient as follows. Can you hear it in only one ear or both ears?
Both ears.
Now, compare bone and air conduction by performing Renay test. Usually, air conduction is greater than bone conduction. Place the vibrating tuning fork on the mastoid process behind the ear and ask the patient as follows. Tell me when you no longer hear any sound.
I can't hear.
Can you hear now?
Yes.